So in this chapter, which is chapter 10, we'll be going over various medical emergencies and some of the competencies that you should acquire per the National EMS Education Standard for assessment and management of the medical complaints of various types. Under neurology, you should be able to understand the anatomy, presentations, and management of decreased level of responsiveness, seizures, and stroke. Some of your abdominal and gastrointestinal disorders, understand the anatomy, presentations, management of shock associated with medical emergencies or abdominal emergencies, as well as gastrointestinal bleeding. And then, of course, there's endocrine disorders, and awareness that diabetic emergencies cause altered mental status. Continuing on, we have cardiovascular, so understanding the anatomy, signs and symptoms, and management of chest pain and cardiac arrest. And then your respiratory, obviously your anatomy of your respiratory system, the signs and symptoms and management of respiratory emergencies, including those that affect your upper airway and your lower airway. And then your genitourinary and renal systems, blood pressure assessment, and hemodialysis patients, and how those differ from people who do not have renal issues. So as an introduction, common medical conditions include angina pectoris, heart attack, congestive heart failure, dyspnea, asthma, stroke, hypoglycemia and diabetic coma, and abdominal pain. Also, to tag onto that, hyperglycemia is also a very common medical emergency or condition as well that you will run across. EMRs can prepare to treat medical patients by studying the signs and symptoms and treatments of each condition, what to look for, what to expect, and what to relay to higher level care responders as they arrive. So patient assessment of medical emergencies. Review your dispatch information. Ask your dispatchers for additional information if you need it while you're en route. Carefully assess the scene and identify safety issues. Remember, we all go home at the end of the day. As you perform your primary assessment, try to form an impression of the problem first, then determine the patient's responsiveness, introduce yourself, check ABCs, and acknowledge the chief complaint. To perform an impression of the problem first, that's kind of like your windshield survey or your scene size up. When you're first arriving, you're walking into somebody's house, you're looking around for indicators of something that might be going on. You're coming up to a car wreck, you're looking at the mechanism of injury, the damage to the vehicle or other vehicles involved. If it's a pedestrian, things like where was the pedestrian actually struck? Were they thrown, dragged, rolled, things of that nature. Usually it is best to obtain a medical history on a medical patient before you perform your secondary assessment, performing your sample history information. Using that format, you can use that with the patient directly or family members, bystanders, to try to start putting the pieces of the puzzle together. This is particularly useful for patients who are cognitively impaired or have some other kind of disorder, that you can go to a family member or a healthcare provider to ask these questions. Sometimes your patient's medical record or their face sheet or their history at a nursing home or something like that can give you more information than the staff can. Monitor your patient through reassessment, and then remember to reassure your patient. When we're reassessing our patients, our critical patients, we want to reassess them at least every 5 minutes. If they're stable and they're talking and having normal conversation and good circulation and breathing, no airway obstructions, things like that, every 10 to 15 minutes is adequate. 15 is kind of the more standard go-to these days. And here you just have a little algorithm. Where's my right here? Your scene size up, primary assessment, history taking, secondary assessment, and then your reassessment. And once you reach the bottom of that, go back and kind of start all over again. A lot of times you'll pick up things on your second go round or your second assessment that you missed on the first time. So for altered mental status, whether it be sudden or gradual decrease in a patient's level of responsiveness, use your AVPU scale. Are they alert? Are they alert to verbal or responsive to verbal? Are they responsive to pain, or are they completely unresponsive? You have AVPU. When assessing a patient's mental status, consider two factors. Patient's initial level of consciousness. Is this their baseline? Are they always like this? Or is this something new? Did this just occur? Or has this been going on for hours or even days? It could be new to the patient, but is this a prolonged or a chronic condition, or is this just their baseline? And then also any change in that level of consciousness. Are they becoming more conscious? Are they getting less conscious? Same thing with you going back to your AVPU. When you first arrive on scene, are they alert to painful stimuli and now they're alert to verbal because you woke them up through painful stimuli, or was it the other way around and decreasing? Conditions that can cause altered level of consciousness: head injuries, shock, blood loss, decreased level of oxygen in the brain due to stroke or a slow heart rate. There can be a high fever, infections, poisoning, low level of blood glucose or even high level, insulin reaction, or a psychiatric condition. So our initial treatment. Maintain your ABCs all the time. Try to maintain a normal body temperature. This may involve hypothermia treatment, active warming, things of that nature. Keep the patient from additional harm. We do no harm. We only try to help and do what's in the best interest of the patient. If the patient is unconscious and has not sustained trauma, place them in the recovery position or use an airway adjunct, and be prepared to suction. A lot of times we assume or we presume that a patient, through our assessment, does not have a gag reflex, and we can use an oral airway. And as soon as we insert that, it's enough stimulus to actually stimulate their gag reflex and cause them to vomit. So having our suction on standby when we do these procedures is important. So seizures, caused by sudden episodes of uncontrolled electrical impulses in the brain. They are very random and spastic. There's a lot of times no rhyme or reason to the process of a seizure. They produce shaking and involuntary contractions of the musculature throughout the body, sometimes in isolated areas and sometimes globally. They last, generally speaking, 1 to 2 minutes and usually leave the patients unconscious afterwards. This is called a postictal phase. A lot of times during the postictal phase, they will become responsive or conscious, but they still will be extremely confused to their whereabouts. They will not remember the seizure. They don't know who you are, because when they went unconscious, you weren't there, and now you are there. You're complete strangers. A lot of times you're in their house. It's not uncommon for patients who go through a postictal phase after a seizure to become slightly combative when they're first waking up. It's not them being aggressive towards you. It's usually a reaction of fear and not knowing what's going on. Generalized seizures that are caused by a high fever are called febrile seizures, and typically occur in infants and young children. That's not to say that it can't occur in adults, but these are typically a rapid onset of fever that causes these febrile seizures. The general or the gradual onset of a fever typically produces less frequent seizure activity. And then, of course, you have absent seizures. These result in only a brief lapse of consciousness. The patients may blink or stare vacantly or jerk one part of their body. Monitor your patient's ABCs and prepare them for transport. Remember, seizures can be caused by epilepsy, trauma, head injury, strokes, shock caused by trauma, or other forms of shock. It could be septic shock or environmental shock. Decrease in the level of oxygen to the brain, the high fevers, infections, poisoning, overdose by drugs or alcohol, brain tumors or infections, diabetic emergencies, complications of pregnancy, and then also other unknown causes. There's a lot of people that suffer from seizures that never receive an official diagnosis. It's just a seizure of unknown origin, and the neurologist just can't put their finger on it. So treatment, what kind of treatments can we do as an EMR? Usually a seizure will be over by the time you arrive on scene. Actually, in fact, most times they are over. If it has not ended, focus on protecting the patient from further injury. A lot of times we'll place something soft under their head, or we'll at least cradle their head. We'll remove other items from nearby to cause them from or prevent them from falling on the patient. Especially if they're on concrete floors, we want to protect their head and their spine. We don't want to restrict the patient's movements and try to stop them from moving. Number one, we're not going to stop the involuntary movement of the muscles, but by restricting them, we actually increase the possibility of causing injury. Once the seizure stops, ensure that the airway is open by placing the patient in the recovery position. If they're not breathing, follow the appropriate steps for ventilation, artificial ventilation of a patient. If the patient does not resume breathing, begin mouth-to-mouth, mouth-to-barrier, or mouth-to-bag valve mask device using rescue breathing. Administer your supplemental oxygen as soon as possible or as soon as it's available. And then after a seizure, move the patient to a more comfortable private place, especially if they're conscious. Unresponsive or not breathing patients after a seizure, we're not going to really worry about their comfort so much as their vital life signs. Specific medical conditions, you will find it helpful to be knowledgeable about some more specific medical conditions that you may encounter as an EMR. This information will help you assess, treat, and communicate more effectively with patients. When you have a familiarity of medical conditions that a patient may have, obviously you can't learn them all, but there are some more common ones that will help you with your assessment and your diagnosis or your differential diagnosis. The heart must receive a constant supply of oxygen or the cells will begin to die. The heart receives its oxygen through coronary arteries. These arteries may become narrowed or restricted as a result of atherosclerosis. The progressive atherosclerosis can cause angina pectoris, heart attack, or even cardiac arrest, depending on the severity. So, angina pectoris, what is that? It is chest pain caused by an inadequate flow of oxygen to the heart muscle, or blood that carries oxygen to the heart muscle. It is often described as a pressure or a heavy discomfort. The patient is often short of breath, sweating, or extremely frightened, has a heightened sense of anxiety, and has a sense of doom, often brought on by exertion, emotion, or eating. Ask if the patient is already being treated for a heart condition and has a prescription of nitroglycerin. You may assist the patient in taking one pill or administering an aerosol spray. If the patient has not lessened, if the pain has not lessened in 5 minutes after the first dose, help the patient take another. If the pain has not lessened in another 5 minutes after the second dose, assume the patient is having a heart attack and transport promptly. Now remember, this is also if the patient is already prescribed their own nitroglycerin. Always follow your local protocols regarding administration of nitroglycerin. Some systems allow EMRs and some systems do not. So be aware of that and be knowledgeable of it. So moving a little bit further down the road onto heart attack. This results when one or more coronary arteries is completely blocked or mostly occluded. Two primary causes of coronary artery blockage is severe atherosclerosis and a blood clot. Signs and symptoms of a heart attack. The patient may suffers immediate or severe pain. Pain may radiate from the chest to the left arm or the jaw or even the small of the back or other portions of the back. And the patient is usually short of breath, experiencing weakness. They're cool, pale, diaphoretic, or sweaty, often associated with nausea, and they may vomit. If the blocked area is critical or a large artery, the heart may stop completely, progressing you into cardiac arrest. Complete cessation of heartbeat is called cardiac arrest. Cardiopulmonary resuscitation, or CPR as we all know it better, is your first emergency treatment. Once you have identified that there is an absence of a pulse, we immediately begin with chest compressions on an adult. You want to call for additional help, radio it, yell it, what have you. Talk to the patient to relieve his or her anxiety. This is pre-cardiac arrest. Touch the patient to establish a bond if they permit it, and then reassure the patient. Move the patient as little as possible and place the patient in the most comfortable position. Help the patient take 1 adult aspirin or 2 to 4 low-dose aspirins. We want that 325 milligrams of aspirin. Typically, buffered aspirin is better. It's easier on the stomach. Administer oxygen if available. Be prepared to administer CPR. Cardiac arrest happens suddenly and usually when we're looking away. You'll be talking to a patient. They'll be complaining of their crushing chest pain. They'll be sweating. They'll be pale. You'll say, okay, let me get you a towel. You'll turn around, and when you look back, cardiac arrest. If an AED is available, have it brought to the patient and make sure it is ready for use. If you're highly suspicious that cardiac arrest is imminent, it's not a bad idea to go ahead and place your pads on the patient and be ready to go. Always follow your local protocol when administering aspirin to a patient. Same thing, some systems with nitroglycerin, some systems will allow EMRs to administer aspirin, some don't. So congestive heart failure is caused by failure of the heart to pump adequately. If one side of the heart becomes weak and can no longer pump adequately as well as the other side, the circulatory system becomes unbalanced, resulting in circulatory congestion. In CHF, or congestive heart failure, the failure is in the heart muscle and the congestion is in the blood vessels. Signs and symptoms of congestive heart failure are shortness of breath, which is a major major symptom. Oftentimes you'll have wet lung sounds as well, which is pulmonary edema. That's the fluid backing up in the circulatory system, backing up into the lungs. Rapid, shallow breathing, moist or gurgling respirations, profuse sweating, enlarged neck veins or swollen-looking neck or distended neck veins. Swollen ankles are usually puffy, and we'll call pedal edema. And then anxiety. So some actions to take is place the patient in a sitting position with their legs down to help drain some of that fluid down with using gravity. Administer oxygen at a high flow rate. This is usually done with non-rebreather at the 10 to 15 liters per minute. Summon for additional help. They are going to need advanced life support, and arrange for that prompt transport. Dyspnea is shortness of breath or difficulty breathing, usually associated with serious heart or lung disease. Heart-related causes can be angina pectoris, heart attack, or congestive heart failure. Other causes include pulmonary disease, such as COPD, emphysema, chronic bronchitis, pneumonia, or asthma. General treatment for this is going to be check the patient's airway to be sure it's not obstructed, check the rate and depth of the breathing, place the patient in a comfortable position and provide reassurance. Loosen any tightening or constricting clothing and administer oxygen if it's available. Asthma is an acute spasm of airway passage associated with excess mucus production and swelling of the lining of the respiratory passage. It can be caused by an allergic reaction, severe emotional stress, exercise, or respiratory infections. Asthma in the United States killed 3,564 individuals in 2017. Patients will have great difficulty exhaling, and a wheezing sound will be heard. Follow treatment steps for dyspnea and instruct the patient to perform pursed lip breathing. So when they are exhaling, they want to purse their lips together and blow through that, and that creates back pressure. And if an advanced life support transport unit is not available, transport promptly. And moving on to stroke, this is the leading cause of brain injury and disability in adults. According to the CDC, approximately 795,000 adults in the United States have a stroke yearly. There were 146,383 stroke deaths in 2017. Most strokes are caused by a blood clot that blocks the blood supply to part of the brain. So signs and symptoms of a stroke are many. We have headache, numbness or paralysis to one side of the body. There are some strokes that will cause paralysis to two sides. This is typically multiple clots on both sides of the brain. Dizziness, confusion, drooling, inability to speak appropriately, difficulty seeing, unequal pupil size, unconsciousness, seizures, respiratory arrest, incontinence, and unresponsiveness. So we have the Cincinnati Pre-Hospital Stroke Scale. This one is still widely used, moderately used in our region. It is used to determine whether a patient may have experienced a stroke, and it requires no special equipment and has a 72% probability of stroke if one of three elements have been found. And if you look here on the left side, there's a table. You have facial droop, have the patient show their teeth or smile. If it's normal, both sides of the face will move symmetrically. If it's abnormal, one side of the face does not move as well as the other or not at all. Arm drift, have the patient close their eyes and hold both arms straight out for 10 seconds. Typically, I'll tell them, I'm going to raise your hands, close your eyes. I'm going to let go of your hands, but I want you to keep your hands where I put them. If both arms move or stay in the same position, that's normal. If one arm does not move or it drifts down compared with the other, that is considered abnormal. Say, can you teach an old dog new tricks? This is for abnormal speech. Normal, the patient uses the correct words with no slurring. And abnormal, the patient slurs the words, uses the wrong words, or is unable to speak or even understand what you said. Any of those can be considered positive for recent stroke or having a current stroke. This is the RACE scale, or the Rapid Arterial Occlusion Evaluation Scale. It is an EMS assessment tool that is widely used in Western North Carolina and is being widely used across the United States. It's kind of taking the forefront in stroke scale assessment. It is used to determine if the patient may be currently experiencing a stroke, requires no real special equipment, has about an 85% accuracy rate, and a 65% specificity rate. If you look at the scale here, you have a score line on the top, 0 being no deficits, 1 being mild or moderate, and 2 being moderate to severe. And on the left column, you have facial palsy, arm motor movement, leg motor, head gaze deviation, aphasia, and agnosia. So you will make an assessment based on these inclusionary or these assessment tools, and then give them a score based from 1 or from 0, 1, or 2, and then you'll add any of those up. If the race score down here, if the race score at the bottom of your screen equals 5 or greater, the patient may have an ischemic stroke with a large vessel occlusion. A lot of times, if you have a patient that you are evaluating for a stroke, it is useful or helpful to use both the Cincinnati pre-hospital stroke scale and the race scale. Most local hospitals around in this region are going to be asking for your race scale or your race stroke scale. So what kind of treatment? First priority is to maintain an open airway. Administer oxygen using a non-rebreather mask. If the patient is having a seizure, try to prevent further injury, and be prepared to administer rescue breathing, as respiratory arrest is common in severe strokes. Place an unresponsive patient who is breathing in the recovery position. Provide emotional support by talking and touching a patient who is conscious. A lot of times there's a lot of confusion and fear associated with a stroke, or with in a patient experiencing a stroke. Some patients can be treated with drugs to dissolve the blood clot in their brain, or devices that go in through a vessel and actually retrieve the clot from within. So you want to, anytime you highly suspect or confirm a stroke, you want to arrange for prompt transport to an immediate or to an appropriate level stroke center. Diabetes is caused by the body's inability to process and use glucose. The body produces insulin, which enables glucose to move into individual cells. If the body does not produce enough insulin, cells become starved for glucose, and diabetes results. Many diabetics take supplemental medications to help manage that. In hypoglycemia, sometimes diet is one of the key treatments. It occurs if the body has enough insulin but not enough blood glucose. Signs and symptoms of hypoglycemia can be pale, moist skin, cool skin, rapid, weak pulse, dizziness or headache, confusion, unresponsiveness, sweating, hunger, and rapid onset of symptoms. These individuals can appear drunk. They can be combative, very disoriented. If the patient is able to swallow and protect their own airway, have them eat or drink something sweet. We carry oral glucose in our first responder bags. So if you are trained and authorized to do so, that is a very quick tool to fix the problem immediately. But remember, once that occurs, that patient does need to eat something substantial, something high in carbohydrates and have some good fats in it as well. EMTs and paramedics will use a glucometer to actually measure the blood sugar level. Never try to introduce anything orally to a patient who is unresponsive and cannot swallow themselves. If the patient is unconscious, open the airway and assist breathing and circulation. Do not administer fluids or foods by mouth. Some EMRs carry a tube of oral glucose or tablets that can be placed inside the cheek. This is also still, if you're authorized to do that, should be used with extreme caution, especially in that kind of scenario or situation. Diabetic comas. This occurs when the body has too much glucose and not enough insulin. Signs and symptoms of this. History of diabetes is a huge indicator. Warm and dry skin, rapid pulse, deep, rapid breathing. A lot of times there's a fruity odor on a patient's breath. Some people associate it with the smell of alcohol or like a mixed drink. Weakness, nausea, vomiting, increased hunger and thirst, and urination. The increased urination, the body is actually trying to flush out a lot of that excess sugar. And this is usually a slow onset over the course of days. Misdiagnosis is fairly common. It is not always easy to distinguish between hypoglycemia and diabetic coma without an actual diagnostics of the blood sugar. In general, give a conscious diabetic patient sugar by mouth and arrange for prompt transport. We can always fix a slightly elevated sugar later on. If a diabetic patient is unconscious, arrange for that prompt transport and manage their ABCs. So here we have a comparison on the left side of the screen between hypoglycemia and a diabetic coma or hyperglycemia. So you'll see hypo is usually their skin will be pale, moist, and cool, whereas with the hyper, warm and dry. Rapid, weak pulse. Rapid pulse, typically with hyperglycemia, you will have a stronger pulse, though it'll still be rapid. Hypoglycemia says here normal breathing, but take that with a grain of salt. If your sugar levels drop too low or too rapidly, it can definitely affect your rate of breathing and your quality of breathing. Hyperglycemia is typically deep and rapid breathing and usually fairly rhythmic. Hypoglycemia is associated dizziness and headache, or headache is associated, and then they're usually confused or unresponsive in both. Hypoglycemia usually is a very rapid onset and catches people off guard, and then hyperglycemia usually takes a couple days for the onset to occur. Talking about abdominal pain. Contents of the abdomen are divided into hollow and solid structures. Hollow structures are really tubes through which contents pass. Solid structures produce substances. So we've got our hollow tubes like our intestines, our stomach itself. Abdominal pain is a common complaint. Acute abdominal pain is caused by irritation of the abdominal wall and may result from an infection or presence of blood in the abdominal cavity. Pain can be referred to other parts of the body. Abdominal pain, or the abdomen, may feel as hard as a board, and some patients may have nausea and vomiting, fever, and diarrhea as well as pain. Some patients will vomit because they are bleeding from the esophagus or in the stomach, or ulcers in the stomach. If a patient has abdominal pain, monitor your vital signs, treat for signs and symptoms of shock, keep them as comfortable as you can, and arrange for prompt transport. They do need to be evaluated for undiagnosed abdominal pain. AAAs occur when one or more layers of the aorta become weakened or separated from other layers of the aorta. Patients who have diabetes, high blood pressure, atherosclerosis, as well as heavy smokers are at higher risk for AAAs. And patients may complain of pain or a tearing sensation in the abdomen and may have pain referred to the shoulder. If a AAA ruptures, the patient will experience severe pain and profound shock. Treatment for this: place them in a comfortable position, treat for shock, handle these patients gently, especially in that pre-rupture phase, and arrange for prompt transport to an appropriate facility. Patients who we are highly suspicious of a AAA that hasn't ruptured yet or presumably hasn't ruptured yet, we want to move them as gently as possible. Having them stand up and stretch out can actually cause that rupture to happen. Kidney dialysis patients, people with certain types of kidney disease are unable to filter waste products from their bloodstreams. Patients with chronic renal failure must undergo hemodialysis. Most of these people have to go to dialysis clinics to receive this treatment, though some people can actually do at-home hemodialysis or even peritoneal dialysis. A patient's blood passes through a dialysis machine that filters out waste products and returns the cleaned blood to the patient. Most hemodialysis patients have a shunt implanted in their arm or leg. Typically, you'll see this on the left side. Most shunt is a surgically created connection between the artery and a vein, and allows that machine to take blood from the body, filter it, return it back into the body. If a patient has a shunt, take the patient's blood pressure in the arm without the shunt if possible. If they have an old shunt and then a new shunt, you may have to take a blood pressure on the leg. Patients who are receiving dialysis may experience medical emergencies related to their dialysis treatment. This decrease in blood pressure can produce shock. Dialysis patients also are at risk for internal bleeding. Hemodialysis patients may experience abnormal levels of electrolytes in their blood. These imbalances can cause cardiac dysrhythmias that sometimes result in cardiac arrest. And then, of course, treat your signs and symptoms that are presented by the patient. Manage your airways, treat for shock, palliative care, keep them comfortable. So we must understand a few principles about infectious diseases so that we can protect ourselves in order to provide a proper care to the patient and help prevent the spread of infectious diseases to other people. Infectious diseases can be spread from person to person in three main ways: direct contact, indirect contact, and then contact with blood. This would be a good time when you're reviewing this chapter to go back and review Chapter 2, which is the workplace safety and wellness, and talks about PPE and infection prevention. An epidemic is an infectious disease or condition that affects many people at the same time in a geographic area. If an epidemic spreads to many different parts of the world at the same time, it becomes a pandemic. EMRs are most familiar with COVID-19 pandemic of 2020, which we are still dealing with to this day. Here is a table with some examples of different pandemics and epidemics in recent history. We have the SARS pandemic from 2002 to 2004. There was a severe acute respiratory syndrome, went from China, Hong Kong, Taiwan, Canada, and Singapore. The Mweka Ebola pandemic, which was Ebola in 2007, that was the Democratic Republic of Congo. We have the swine flu, or the H1N1 pandemic, 2009 to 2010, which is pretty much worldwide. MERS pandemic, or Middle East Respiratory Syndrome, was 2012 until present, which is also worldwide. And then we had the COVID-19 pandemic, or novel coronavirus, because we all know coronaviruses have been around for a very, very long time, from 2019, late 2019, until present. And like I said, we're still dealing with that today. So let's summarize this chapter. General medical conditions may have different causes, yet result in similar signs and symptoms. Usually, it is best to collect medical history on a patient experiencing a medical problem before you perform your physical examination. Altered mental status it can be sudden or gradual. Decrease in the patient's level of responsiveness. When assessing an altered mental status patient, use your AVPU scale. Seizures are often caused by sudden episodes of uncontrolled electrical activity or impulses in the brain. Sometimes they remain undiagnosed. Sometimes they can't. A diagnosis can be found. Specific medical conditions including angina pectoris, heart attack, congestive heart failure, dyspnea, stroke, hypoglycemia, diabetic coma, which is that hyperglycemia, abdominal pain, and infectious diseases. So we've got a few review questions here. We'll go over those. Signs and symptoms of a stroke include all of the following except A, numbness or paralysis, B, high fever, C, drooling, or D, unequal pupil size. Answer for that one's going to be high fever. Though that doesn't mean that they can't have a high fever from another disease process or medical condition that's happening at the same time. Number 2, which of the following actions would not be appropriate when managing a patient who is suffering a heart attack? Is it A, place the patient in the most comfortable position, B, administer oxygen if it is available, C, be prepared to administer CPR, or D, move the patient as quickly as possible to the ambulance for transport? They are, after all, suffering a heart attack. The answer, of course, is D. We do not want to move the patient as quickly as possible to the ambulance for transport. Just to spin off of that, the more agitated and the more exasperation we cause the patient, the greater the workload on the heart. If the heart's already experiencing a heart attack, the more likely we will increase the amount of damage or even possibly kick them into cardiac arrest. Hypoglycemia occurs when a patient A, consumes too many high-fat foods, B, has enough insulin but not enough blood glucose, C, suffers from severe dehydration, or D, has too much blood glucose and not enough insulin. That is, hypoglycemia occurs when a patient, A, B, C, or D. The answer is B, has enough insulin but not enough blood sugar. All right. And that wraps up our Chapter 10, Medical Emergencies. Like I mentioned before, go back for your infectious diseases, review Chapter 2 in disease prevention, as well as reviewing Chapter 10. Look at your learning objectives for Chapter 10, which you will find in your My Courses page. If you have any questions or any issues, please feel free to email me or your other lead instructors, or put a message in the classroom chat. And we will be covering Chapter 11 next. Thank you for your time.